esteemed faculty members and our dear colleagues. Today we have a guest lecture for which I would like to invite Dr. Harshvardhan sir to introduce our guest and give a welcome note to him.
Dr. Sudhir Satyaji, Dr. Hemant Malhotra, senior colleagues in the faculty and residents. It's really a great pleasure for us that Dr. Raman Puri is here to discuss with us on the subject of managing dyslipidemias in adolescent population, asymptomatic people. We nowadays keep on hearing the news every day that such and such person died young without having suffered any heart attack or any heart disease in the past. And this news has become very common now, and we have lost some of our young colleagues also because of heart disease, and previously they didn't know about this heart disease and all that they had was a sudden cardiac attack. So it's high time that we have to think something about it and do some active measures so that these deaths in young people can be prevented. And we know that most of these sudden cardiac deaths are because of the coronary artery disease. And the coronary artery disease doesn't develop overnight. The seeds of coronary artery disease are sown even in our childhood. And so steps have to be taken right in childhood and adolescent so as to control this disease so that the disease doesn't develop. We know various risk factors for development of coronary artery disease, diabetes, hypertension, smoking, and one of the most important is dyslipidemia, which we ignore many times and don't treat properly. And if at all we treat as a secondary prevention when the person has developed the heart disease or heart attack or coronary syndrome. But we need to take steps before the first heart attack or before the development of coronary artery disease. So we have various guidelines to guide us how to treat these dyslipidemias in our young adult population, how to treat these dyslipidemias after a person has got heart attack, and how to treat these dyslipidemias when a person has got acute coronary syndrome or stroke. So far we have been depending upon the guidelines which were developed by the Europeans, Americans. In this regard, the Lipid Association took a very active initiative to develop guidelines for our Indian populations. And they have developed a lot of guidelines in asymptomatic coronary artery disease, in stroke patients, in acute coronary artery syndrome, and what are the targets that we should strive to achieve to prevent this heart disease. And we are lucky that we have chairman of the Lipid Association of India, Dr. Raman Puri, who has taken this great initiative to develop these guidelines. I have been in some of the expert panels, and I tell you all the scientific data is discussed threadbare before this guidelines are developed. So I request Dr. Raman Puri to give a talk how we can treat this dyslipidemia in asymptomatic adolescent and prevent a lot of sudden deaths that are happening nowadays. Dr. Raman Puri, please.
Good morning, everyone, and thank you very much, Respected Chairperson, for giving an opportunity to me, and I'm thankful to Dr. Harshvardhan for considering my request to present before you what should be our lipid profile, what should be the lipid profile of young people like you all. And the main objective is very clear. We want to prevent heart disease, and prevent heart disease in you all, your parents. They are also very important to all of you. And so that we should know that it should not be ignored. So I'll give you some important information about it. I'll try to convince you that once after this meeting you go and get your lipid profile checked. And if required, you can always discuss with Dr. Harshvardhan for that. Will this work? This was working. This was working. How many of you know about your lipid profile? Nobody from this. students. And how many of you know what is your LDL cholesterol? See, what is common in these photographs? They are from legends from Bollywood, from the field of cricket, and from our medical fraternity. They all died suddenly. And this is from the media. A man had chest pain, went to a chemist shop to get medicine, and he died there. Ahmedabad girl, class 8, she died in school. Postmortem revealed myocardial infarction. And if you look at the eye, there is some yellowish discoloration there. That is nothing but deposits of cholesterol. Now, question comes, can we prevent coronary artery disease? Can we prevent heart attack? Answer is yes. These are 9 modifiable risk factors which are responsible for 90% of acute myocardial infarction. If you look into out of these 9 modifiable risk factors, lipid abnormality has the maximum association with coronary artery disease. The population attributable risk is around 50%. A person of diabetes, if they die of coronary artery disease, it is LDL cholesterol. Hypertensive person who dies of coronary artery disease, it is lipid abnormalities. Any abnormality, any disease, eventually, if leads to myocardial infarction, the main culprit is your lipid abnormality. And lipid abnormality is the most neglected, factor. We are not concerned. We are concerned about diabetes, what is HbA1c, is it controlled or not. Remember, 75% of diabetic patients they die of coronary artery disease. And the main factor, of course, is LDL cholesterol. Now, I'll give you some basic, about lipoprotein, so that it will be very easy for you to understand. There are some circulating lipoproteins like chylomicron remnant, which is produced from the intestine, VLDL, which is produced in the liver, and it loses triglyceride, becomes remnant, then intermediate density lipoprotein, then LDL particles. So LDL particles comes from partial lipoprotein small a and then HDL. And all these particles carries varying proportion of cholesterol and triglyceride. If we calculate the cholesterol content of all these particles, that is what exactly you look at is the total cholesterol. So particles can be divided into 2 groups. Group 1 is ApoB containing particles. There is an ApoB which is attached to this lipoprotein. So this is important because this is the particle which is going to initiate process of atherosclerosis, is going to cause the disease. So it is called bad cholesterol, you can say, or it is called atherogenic cholesterol. And other is an ApoA carrying particle which is called as an HDL cholesterol, which is an anti-atherogenic, removes cholesterol from the peripheral tissues. Most important part is that each ApoB containing particles contains only one ApoB. So if you know the number of ApoB in circulation, you can find out that how many of these atherogenic particles are in the circulation. So that is the most important. Whereas HDL, you can have number of ApoA. So that is the important difference between ApoB and ApoA. Now if I remove or subtract HDL cholesterol from the total cholesterol, what we get is the non-HDL cholesterol. It's a very simple, total cholesterol minus HDL cholesterol is the non-HDL cholesterol. Now what is this non-HDL cholesterol? Non-HDL cholesterol means it calculates all the atherogenic cholesterol present in these atherogenic particles. And 80% of this cholesterol is carried by LDL cholesterol. Therefore we always target LDL cholesterol, because 80 to 85% of all atherogenic particle is carried by the LDL particles. So non-HDL cholesterol is total cholesterol minus HDL cholesterol. Now, as I said, that LDL cholesterol carries 85% of this cholesterol. The remaining 15% or 20% is what is called remnant cholesterol. So remnant cholesterol is calculated if I remove LDL cholesterol and lipoprotein small a. So it's a total cholesterol minus HDL cholesterol minus LDL cholesterol. Why I have used these words, I've tried to explain to you because in my discussions, subsequent discussions, I'll be talking about these parameters. Based upon number of studies, there is no doubt that LDL cholesterol is a terrorist. It is going to cause harm to you when, where, at what age, nobody knows. So when it is a terrorist, you have to bring it down, the number. Earlier you bring it down, better it is going to be. So that is, I think, the correct word. You can understand how significant LDL cholesterol is its contribution towards myocardial infarction. Now, if we look into the stages of progression of atherosclerosis, as Dr. Harshvardhan said, the deposit starts quite early. In one of the autopsy series of those children who died of an accident, the fatty streaks were seen as early as 10 to 20 years of age. And it takes about 30 to 40 years for it to mature into fibroatheroma, which normally, if it is causing 90% or 80% block, the person gets, angina on effort. When he walks, he gets chest pain. When lining of this fibroatheroma gets ruptured, within matter of seconds, the clot forms, and patient presents to us with acute coronary syndrome. And one of the manifestations of acute coronary syndrome is acute myocardial infarction. It is so sudden that majority of patients, they even don't reach to the hospital. They die because of electrical instability, which we call as ventricular fibrillation. So we have to prevent this, and since it takes 30 to 40 years, almost all of you, majority of you will forget once you leave this hall about lipid profile, because for many years you will remain asymptomatic, so you will not bother about it. That is what I want to just tell you, that don't ever neglect this LDL cholesterol in this. But there are some few factors which accelerates the process of atherosclerosis. Means instead of 3 to 4 decades, it may become 2 to 3 decades. So like hypertension, diabetes, smoking, high triglyceride, high LDL cholesterol. And female, fortunately, hormones, the progression is delayed. So therefore, the chances of female getting myocardial infarction incidence is much lower during the reproductive phase, and of course after that, the incidence is almost same. Now question comes, when should we have a lipid profile? What should be the age of lipid profile? The US Preventive Service Task Force says 35 years for men and 45 years for in women. And CSI, Cardiology Society of India, in 2014 recommended over 30 years of age. We don't agree with either of these, because if you look into the facts of coronary artery disease in India, 40% of Indians, those who have coronary artery disease, are less than 40 years of age. And approximately 25% of those dying of coronary arteries are less than 40 years of age. We developed coronary artery disease 10 years earlier than Americans and other ethnic groups. And remember, this coronary artery disease is more severe and it is associated with very high mortality. We have 4 times more chances of heart disease as compared to Americans, 7 times more than Chinese, and 10 times more than Japanese. That shows that we are a different ethnic group. We have to be very careful. Even in 2018, American College of Cardiology said that if you are an Indian, you are itself a risk factor. Being an Indian is a risk factor for coronary artery disease. So in 2016, we came out with the recommendations that everybody at age 20 should have lipid profile assessment. Or I'll request the chairman that you should recommend lipid profile screening and blood sugar assessment of any person who is entering into the medical college. Why? If you have 600 students here, 650 students approximately, remember 2 to 3 of you all will develop heart disease or heart attack in 40 years time, for age of 40 or 45. Why I am saying this? Because there is a condition called heterozygous FH. The incidence of heterozygous FH is 1:250. If this is the incidence in the population, so out of 600 or 700, 2 or 3 of you all, those who are the students here, they have chances of developing heart disease in near future. So to catch these 2 to 3 persons, if you do lipid screening routinely of all, this very simple test, you have to know only LDL cholesterol and what is your non-HDL cholesterol. You can catch these 3 students and prevent heart disease in near future. In 2020, we came out with update and we recommended that lipoprotein A and ApoB should be also included in standard lipid profile. If it is possible, because these are expensive tests, it may not be done in all patients. Whenever when I talk of dyslipidemia, is a word, it may be because of abnormality in any lipoprotein. Means it can be high HDL, it can be high triglyceride, it can be low HDL, it can be high lipoprotein small a, or in combination. So this word used dyslipidemia, which I will be using more frequently, means any of these abnormalities. So whenever there is a dyslipidemia, try to find out the cause for dyslipidemia, because if you find a cause and you treat, you may not require lipid-lowering drugs, and you can prevent coronary cardiovascular events. Remember, two endocrine problem, there are a number of causes, 8 important, two endocrine, hypothyroidism, Cushing syndrome, two metabolic, diabetes and metabolic syndrome, two renal problems, CKD and nephrotic syndrome, and two hepatic problems, obstructive jaundice and primary biliary cholangitis. These diseases, some may increase cholesterol, some may increase triglycerides, some may increase both these ones. So, treating the primary problem, you will be able to treat this dyslipidemia. Now, coming to this, that what I'm going to say now, do we have any randomized controlled trial to authenticate it, that what I'm saying is right or wrong? Remember, we don't have any randomized controlled trial, because to prove a randomized controlled trial in asymptomatic people, we have to keep these patients giving medicines for many years, bringing down the LDL cholesterol, because it's a very slow disease process. It will take 20 years, so it is not possible to have an RCTs. So from where we get the information? We get information from various population-based studies. Now, for example, which of course I'll discuss before I go into the population-based studies. Remember, I'm going to use some words which are very important for you to understand. That is a cumulative LDL cholesterol exposure. What is cumulative LDL cholesterol? You know, in smoking, there is a pack year, that how many cigarettes of packets of cigarettes you smoke, because it has a strong relation with the carcinoma lungs and other problems. Similarly, cumulative LDL exposure is important for us. That is what it is, the LDL cholesterol multiplied by the year of exposure. Why it is important? There is a threshold to which these arteries, when exposed to, the manifestation of coronary artery disease start appearing. Now let us presume that this threshold is 5,000. Someone who has an LDL cholesterol of 50 milligram from birth, it will take 100 years for it to have this threshold. So this person will not get any coronary problem up to 100 years. If it is 80, then if it is 80 milligram, he will develop heart disease first time at age or somewhere around 60. If it is 125, he will develop heart disease somewhere around 40. And if someone has an LDL of 200, he will develop heart disease at 20 years. And if someone has 500 milligrams, he will develop heart disease, as in homozygous effects, as early as 8 to 10 years. Rather than by 20 years, he will die. So it is very important for us to understand that what is your basal LDL cholesterol, and because it tells you that what is your chances of having heart disease in near future. Now, if I bring down LDL cholesterol, say, now this slide shows that if homozygous FH threshold is reached at 12.5 and in heterozygous untreated, it is 35 years. Now, if I give statin at age 10 and marginally bring down LDL cholesterol by 35%, because low intensity statin reduces LDL by about 30 to 35%. See, the age, the threshold which was initially untreated was 35, it has become now 53. Now at 53 he is going to develop heart problem. And if I start high intensity statin at age 20, there is a benefit, but benefit is less as compared to giving low intensity statin at age 10. So this means earlier you bring down LDL cholesterol, greater is the benefit in the long run. So it's very important, one, to know what is your baseline LDL cholesterol, and second, if it is high, to bring down to the target as early as possible. Now, another important, important information. If I reduce LDL cholesterol by 40 milligrams, whatever the level may be, from 200 to 160, 160 to 120, 120 to 80, 80 to 40. In 5 years, I am going to reduce event by 22%. Only 22% reduction will be there. This will go to 32% in 12 years. And the event reduction will go up to 53% in 50 years. Remember, it's earlier you treat it, longer you treat it, greater is the benefit. That is what exactly I am saying. Once you bring down LDL cholesterol, people say stop medicine, your LDL has come down. That is the wrong thing. You have to keep the low LDL cholesterol for a longer time. Now coming to the observed population-based study, this is a Korean study of 1.2 million population. Here it was found, and age group was 20 to 39. That is exactly the age right now. Most of you are here in around 20 to 25 or 30. And median follow-up was 5.2. It was seen that the chances of having myocardial infarction and stroke was 35% higher in those who had higher level of cholesterol as compared to those who have a low level of cholesterol. And 41% higher those who had a higher LDL cholesterol as compared to lower LDL cholesterol. Remember, the duration is only 5.2 years. It's a population-based study. It's a very large population of 1.2 million. Now another study is 30 years follow-up, in which 100,000 populations were involved. Here, those patients who had non-HDL cholesterol, which I told you what is non-HDL cholesterol, which is total cholesterol minus HDL cholesterol, the incidence of events were much higher in those who had LDL cholesterol more than 230 milligram as compared to those who had non-HDL cholesterol less than 100 milligram. That is important for us to understand that these are all asymptomatic people. They have no coronary problem. These are all, long data which we have with us on population on epidemiological studies. Then we have ApoB. It has been seen that those people who have higher ApoB have higher chances of year 25 coronary calcification. Means if you have ApoB at a higher level, and I follow up you for 25 years, the chances you are having calcium deposited in coronary artery will be much higher in those who have a higher ApoB value as compared to those with lower ApoB value. So, but these are all, observational studies, population-based studies, and epidemiological studies. We have no RCTs with us at present. Now coming to lipoprotein small a, this is a very hot topic nowadays. It's a particle which is both. It's a hybrid particle, hybrid LDL particle. It is LDL particle which carries ApoA, which is called as HDL particle. So it's a combination of this. Rather than having ApoA, the erythrogenesis should come down, rather it goes up. It is one of the cause for increased prevalence of coronary artery disease in Indian population. About 25% of Indian population have high lipoprotein small a. So it's very important, and based upon this, we have recommended that lipoprotein A should be a part of standard lipid profile at age 20. Now I'm just discussing a case with you, and you will be very happy. You will tell this patient, go back home, it's a wonderful lipid profile, don't worry. 30-year-old Indian ethnicity, no heart, no disease, no morbidity, no diabetes, no hypertension, not a smoker, no CKD, blood pressure 120 by 80, height 170, BMI normal, lipid profile, total cholesterol 175, LDL cholesterol 110, triglyceride 150. I think you will all be satisfied with this report. You will never recommend any treatment for this person. Agreed? Even I will also give a second thought for treating this patient. Now, if I calculate his lifetime risk means what is the chances of this man getting heart attack at age 80? That is what is important, because it's a slow process. It will take time to cause heart problem. This is a JBS3 risk calculator by which you can calculate that what is your chances of having heart problem at age 80. Indian ethnicity, the chances of having heart problem is 37%. Now, with the same baseline characteristics, I'm not changing it. I change Indian ethnicity into the other ethnic group. It comes down to 25%. Being an Indian, we have 12% higher chances of having heart disease as compared to other ethnic groups. That is what I want to stress upon all of you, that being an Indian is good to be an Indian. Happy, it's a wonderful country, but at the cost of high chances of coronary artery disease. But why we have high prevalence of coronary artery disease? This is a lipid profile of an American and versus an Indian. This is done in USA. You will find, if you go into detail, that Indians have significantly lower LDL cholesterol, significantly lower HDL cholesterol, significantly lower non-HDL cholesterol as compared to Americans. But they have significantly higher triglyceride, significantly higher ApoB as compared to Americans. So high triglyceride, low HDL, and LDL cholesterol normal or mildly raised is what is called as atherogenic dyslipidemia. Why atherogenic dyslipidemia is dangerous? Because whenever the triglyceride goes up, the LDL particle becomes small, which we call as a small dense LDL particle. And you can understand if the particle is small, it will get into the subintimal space and can initiate process of atherosclerosis. And so they are more dangerous. And therefore, this is one of the reasons for why Indians have high chances of having coronary artery disease. This is a study which we did in school-going children. Remember, I am an interventional cardiologist, remember. But I have a passion for lipids because there we treat with stent or bypass. Here we prevent, and prevention is extremely important. And I tell in my meeting that if an intervention cardiologist put a stent and patient comes with a recurrence of angina with a new lesion in coronary artery disease, it is you are responsible for his subsequent myocardial infarction, not the patient. So very openly I blame doctors that you have to look seriously into this particular important aspect, because lowering LDL cholesterol to the target which I discussed will prevent these future events. Here we found that in a school-going children of 14 to 18 years, there was 40%, 45% high incidence of atherogenic dyslipidemia. Remember, that shows that this is one of the most important, observation we had from this study. Therefore, don't think that you are 20 and you are immune from coronary artery disease. No, the process has started, and of course it takes longer time. So there are other reasons also. I will not go into details now. Now, based upon why we had incidence of coronary artery disease, lipid association came out for the first time. Our expert consensus statement. It took us 2 years to make this expert consensus in 2016, and we were the first association in the world. People, of course, threw stone on us. We recommended LDL cholesterol less than 50 milligram in patients with established coronary artery disease. At that time, all international guidelines were saying less than 70 milligram, but we were the only country to say less than 50. Of course, European guideline in 2019 came down the target to less than 55. Once they come to 55, we were respected a lot. Initially, they used to throw stones on us, but after that, we got a lot of love from them. And here we divide these patients, we classify patients into, in our updated 2020 into 5 groups. Right now, those who are young and asymptomatic, they fall into low and moderate risk group. So most important is that. It's not easy, it will be very difficult for me to go into very extensive. You can always ask Dr. Harshvardhan to have another lecture on this. You classify patients into whether it's a low risk group or moderate risk group, high risk group, very high risk group, and extreme risk group, which is further divided into category A and B. But we'll restrict to low risk group and moderate risk group. If you have no or one major ASCVD risk factor, which you can see on the corner, there are 5 risk factors. You fall into low risk group, but your lifetime risk has to be less than 30%. If you are in a low risk group and your lifetime risk is more than 30%, you become moderate risk group. And a moderate risk group also has two major ASCVD risk factors. And low risk group patients, if they have on the extreme left, you can have moderate non-conventional risk factors. They are classified as a moderate risk group. So try to read this. I will not be able to explain you in proper. Classify your patient to low risk group and moderate risk group. You can very easily do it, and then we can try to achieve the targets. Now, what are the targets for low risk group? Less than 100 milligram for low risk group and less than 100 milligram for moderate risk group. Our 2023 update, which will be published another 4 months from now, in moderate we have made LDL cholesterol optional less than 70 milligram. And remember one thing, I am giving you a very important statement, that everybody should try to keep, those who are young, no risk factor, I am talking those who have risk factor, the targets will change. Everybody with no risk factor should try to keep LDL cholesterol around 70 milligram. That is basically a physiological level of LDL cholesterol. If you have LDL of 70 milligram, neither cholesterol will deposit in the artery nor it will regress. Neither there will be progression nor there will be regression. So try to keep LDL cholesterol around 70 milligram. Those who have no coronary artery disease or they don't fall into very high risk group, high risk group. I'm talking of low risk group and moderate risk group. These are the targets which you can always go. Regarding triglyceride, try to keep fasting triglyceride less than 150. For Indians, we recommend less than 100 milligram. And these are ApoB levels. Now this is the algorithm which we have made for how you should manage patients who are asymptomatic. You classify patients into low risk group and moderate risk group. Low risk group, we have put a lot of emphasis on lifestyle intervention, and you give 6 months, so 3 to 6 months time for lifestyle intervention. If the target is not below 100, then you can consider using low dose statin even in patients who are in low risk group. In moderate risk group, you can start statin without waiting for 3 to 6 months for lifestyle intervention. And of course, the targets and approaches changes as the patient is in high risk group or very high risk group and extreme risk group. Now, I will conclude now that despite the absence of RCTs, there is enough evidence to support the benefit of early screening of dyslipidemia and its treatment in reducing cardiovascular event. Dyslipidemia should be evaluated at age 20 or earlier if there is a family history of premature ASCVD or familial hypercholesterolemia. If possible, include lipoprotein A and ApoB. Classify the subject into one of the ASCVD risk category. Calculate the lifetime risk in patients with low risk group. If it is greater than 30, the low risk group patient is reclassified as a moderate risk group. Reach to the target what we have recommended of LDL cholesterol and non-LDL cholesterol. Remember, if the triglyceride is LDL is more than 160 milligram, that patient falls into high risk group, so you have to start with high intensity statin. Foundation for managing dyslipidemia in all ASCVD risk category is lifestyle intervention. Identify and treat all modifiable risk factors and secondary. Don't forget to treat hypertension. Don't forget to treat diabetes. Don't try to achieve whatever the targets have been recommended for these diseases. So take home message is that testing lipid profile does not require a fasting. Now forget about fasting lipid profile. I'll use the word, it is being stupid to go for a fasting lipid profile. I'm using the word stupid. You will say, why Dr. Puri, you are using the word stupid to do it. Reason is this, that almost 18 to 20 hours in a day, we are in a non-fasting state. And this is, the non-fasting lipoprotein to which our arteries are exposed to. And to be fasting, you have to be more than 8 hours fasting, which is practically not possible. So it's always better to screen patient in non-fasting state, because non-fasting HDL cholesterol, you may have a normal fasting, lipid profile, triglyceride, everything normal. You will have abnormal, high triglyceride when you are in a non-fasting state. So it's very important to do it and try to achieve the target, what I'm saying. So what I said, you should try to keep your LDL cholesterol around 70 milligram. So what I would like to request all of you is that whatever I talked, take it seriously. And my purpose of visit is this, that you are the future of our country. We are almost, how many years we are going to live, we don't know. So take care of your parents. And it's a very simple test to do, and you can prevent. I assure you one thing, that I've been doing intervention for many years, and I've got number of patients of angioplasty, post-angioplasty in CABG. Majority of my patients LDL is around 30 milligram or 40 milligram. My main practice today is all those follow-up with me who are coming and showing me for the last 20 years. 70% of my practice is that. So event reduction is so less with low level of LDL cholesterol that it will be a source for your income also when your patients come to you after 10 years. Thank you very much for your kind attention.
And I think that should cautious all of us that we have to take action regarding our cholesterol levels and take that action early. Rightly so, all the medical students are also here, the residents here, and that is the age when they should start action. And I'm sure they will have a lot of questions because nobody wants to take medicine right from the young age. So what are the lifestyle measures that they should adopt before they go into statins? And it's an Indian psyche. Nobody wants to take medicine for, say, 30 years, 40 years. So what are the lifestyle measures that they should take before they resort to medicines to achieve these targets of ideal cholesterol?
But I tell you today that going for regular lifestyle intervention is extremely difficult. None of us will follow. Tell me, how many of you go for 45 minutes to 1 hour walk every day? Hardly any. Hardly any. When a patient comes to a doctor, he says, don't give me medicine, I will go for a lifestyle. I assure you, he will never go for it. He will go it for 1 month, 2 months, finally one day he says, no, I want to relax, have a cup of tea, coffee in at home. It will not go. So it is more of a deceptive, thought process. It will never happen. But it doesn't mean that we have not to strongly emphasize on it. If he does it, it is good. Now, what is my strategy? I just tell you that I am taking statin for the last 30 years. 30 years means when I was 37, 38 years. My LDL is always less than 50, around 45, 46. What is wrong in taking statin? I'm not saying, I'm not advocating statin at all. If you can bring it down, because there is no doubt there is a strong relation of LDL cholesterol. I am again emphasizing you very clearly. Very strong association of LDL cholesterol with coronary artery disease. We see those with homozygous haploid children, remember, they die at age 15. They get bypass surgery done at 7 years of age, 6 years of age. So why to keep this, evil in your blood circulating and enjoying all the fun and making your life miserable? Well, if you want to practice lifestyle, brisk walking is the best exercise for you to do. Brisk walking of 21 miles per week, that comes about 4 to 5 kilometers in 40 to 45 minutes, should be a regular exercise. This means it's walking 5 kilometers in 40 to 45 minutes is the brisk cardioprotective exercise, number one. It should be your daily affair. It's not twice or thrice in a week what American says, you do moderate intensity and low intensity. So this is important for us. It's very important because it may not reduce your LDL cholesterol. Remember, exercise never reduces LDL cholesterol. It is your diet which brings down LDL cholesterol by 10 to 15%. But exercise reduces triglyceride, and it changes small LDL particle into a large LDL particle which doesn't get into the subintimal space. So LDL cholesterol will remain same, but the quality of LDL particles improve. It becomes larger, so it will not get into the subintimal space. Number one. Number two is that regarding fat intake, which is extremely important, and milk, what should be a double tone milk or this thing. We are not very, there is no trial which shows that if you take double tone milk versus full cream milk, of course full cream milk we will not recommend. It's going to make any disease in future. If you keep your LDL cholesterol to the target, but whatever means it is always, you can enjoy all the food, because life without good food is not good. And being Punjabi, and we are all fond of eating, good food. So you have to make sure that this entertainment and enjoyment should not be more than once or twice in a week. Rest 5 days in a week you should have a balanced diet. And oil consumption should not be more than 15 ml a day. 15 ml a day per person. So it becomes 450 ml per month. That is very important for us to keep, And that includes ghee also in case we say. Though we don't say no to ghee, but we are not liberal with ghee. You can enjoy it. See, now our policy has changed, We do not say don't take this, don't take this, don't take this. Take it in moderation. That is extremely important. You can just imagine if somebody is fond of pranta, you tell him that you will not take pranta, he will jump from 5th floor. He says, what is the life, Dr. Puri is enjoying pranta and refusing pranta to me, Take pranta, you tell him that to take twice in a week pranta. So he'll wait for those 2 days for pranta, but he'll follow the other things. You cannot stop everything. 2 eggs, 2 to 3 eggs in a week with yellow is okay. With white you can take it every day. And that is exactly, you have to do it. And never take heavy meal. If you want to have 3 chapatis, you can take 2. You can have more frequent. That is all. Never walk after the meals. That is very important, because it's not good. Because when you take meal, your pulse rate goes up, your blood pressure goes up. So your already heart is on stress. There is no point in doing it. So that is all. And in winter, you should not go for a walk exposed to the cold, because you can cause coronary spasm. So these are all precautions you can take. And we have a very good article on our 2020 update in Lipid Association Expert Consensus. Perhaps you can discuss about it. Regarding oil, I will say that we have given in our recommendation mustard oil, that is extra virgin oil, as the oil number 1, then canola and rice bran are the oils which we can use. Never use olive oil for heating purpose. Never use it. You can put it on the salad, but never cook things with the olive oil. It's not much because we have a tie-up with Lal Laboratory. They give us ApoB, lipoprotein small a, and standard lipid profile in just 700 rupees.
Are we doing ApoB and kindly start both? Kindly start both, and I request DC that all who are admitted in Mahatma Gandhi Medical College or Dental College University, at the time of admission, they should have screening of lipid profile, including these things, plus blood sugar, random blood sugar. And it should be free. It will be free, and it should be done. And for those over 35, 50, any faculty member, they will have yearly checkup, and university should ensure that. And what should be the dose of statin?
See, you have to achieve the target. If you achieve the target with 5 milligram of atorvastatin, 5 is good enough, 10 is good enough, 20. See, it depends upon how you respond. There have been a trial, Jupiter trial, in which 20 milligram of atorvastatin was given to a young asymptomatic person. You will be surprised that 10% of the patient did not have any fall in LDL cholesterol. And 43% of patients had LDL cholesterol fall of less than 50%. And about 44% had a fall of more than 50%. So it's a heterogeneous, you never predict. But rosuvastatin as such, normally in high intensity statin reduces LDL by 55%. So those, we cannot fix a dose. It's a target-based treatment. Any statin which is comfortable with you. But if you look into some of the potential adverse effects, atorvastatin is a lipophilic drug which can diffuse into any tissue. So muscle pain has been reported slightly higher. In one of the Pramo study, they found that the incidence of muscle pain was around 14 to 15% in the general population. And rosuvastatin has less problem. Then atorvastatin is a better drug in CKD because it prevents proteinuria. So I think that there are minute differences between two, but any statin, if a person is comfortable with, is good enough.
मैं चाहता हूं कि हम सब लोग अपनी अपनी जगह खड़े होकर के जोरदार तालियां बजाकर डॉक्टर पुरी का स्वागत करते हैं। मैं आमंत्रित करूंगा परम आदरणीय डॉक्टर स्वर्णकार जी से, हमारे संस्थापक, हमारे एमेरिटस चेयरपर्सन, के वे आए, आकर के पहले संबोधित करें, फिर हम चाहेंगे कि हम डॉक्टर स्वर्णकार जी के द्वारा आपको सम्मानित फेलिसिटेट।
मंत्री जी, आज बहुत ही अच्छा ये आपने बड़ा प्रैक्टिकल जो चीज़ है वो समझाई, और मुझे खुशी है कि अब जो हमारे यहाँ नहीं हो रहा था वो भी और हर हालत में शुरू करेंगे, और स्क्रीनिंग भी सारे डॉक्टर्स की जो भी एडमिशन लेते हैं या जो भी काम कर रहे हैं वो भी हम करेंगे। तो एक अच्छी चीज़ है। और बाकी बेस्ट पार्ट तो ये कि एक्सेस किसी चीज़ का नहीं होनी चाहिए। जहाँ तक मैं समझ पाया हूँ, आप अपनी लाइफ का एंजॉय करें, अच्छा खाएं, कहते हैं ना युक्त आहार विहार से युक्त कर्मश्य श्रेष्ठ। आप अपनी लाइफ में बैलेंस, सम व्यवहार रखिए तो ठीक रहेगा। आज आप आए इसके लिए